So it's my absolute pleasure to welcome you to this breakout session, which is addressing gender disparities within the response to the COVID-19 outbreak, evidence from emerging research. My name is Clare Wenham. I'm an assistant professor of global health policy at LSE, and I'm speaking here today on behalf of the Gender and COVID Working Group and the Gender and COVID Research Project that I'm co-leading with a bunch of fabulous ladies who are on this call with us today. It's my pleasure to introduce you to our panelists. We have, in no particular order, we have Dr. Denise Nacif Pimenta, a researcher from Rene Rachou Institute in Fiocruz, Brazil. We have Dr. Sabina Rashid, the Dean and Professor at BRAC University in Bangladesh. We have Ngunijiri, a Senior Technical Advisor at LVCT Health. And finally, Dr. Germaine Furaha, the Director of the Center of Excellence, Denis Mukwege, at the Universite Evangelique on Afrique in the DRC. We are delighted to have you all here. This session is really trying to think about and look at what's the data showing us. We know a lot about gender disparities in health more broadly. We know a lot about how gender has impacted men, women, and groups of other genders differently in other outbreaks, such as from Ebola, such as from Zika, from cholera outbreaks. But what we're really trying to show you here today is to bring some flavor from the research that our project is doing, the Gender and COVID Research Project, to really understand the current real-time research that we're doing and try and present some of the findings that are coming from our case study countries and from our research to go beyond the generic statements. We all know that women are disproportionately affected by outbreaks and by COVID. This whole day, this whole summit is demonstrating that in different ways women are affected. But we want to really show you some real-time evidence to really back this up. It's so important that we recognize that it's not just about women's health. It's not just about women as health workers. There are a whole variety of gendered effects of outbreaks, which we see time and time again. And the more data we can generate and then present to policymakers gives this real opportunity for a gender transformative change and really pushing for a new way of thinking about outbreaks, a new way of thinking about who is affected and not just infected with outbreaks, and trying to develop a policy and responses which reflect the needs and demands for those who are at risk and or affected. But you don't want to hear from me. So I'm going to start posing some questions to our panelists, and we really look forward to all their responses. If anybody wants to ask questions to our panelists at any time, please can you type them into the Q&A, and then Rosemary Morgan, who's here with us as well, will be moderating the Q&A at the end of the the end of the first starting comments that our panelists are making. Please do ask at any time, and we really look forward to this being an engaging but collaborative discussion. And please, we really welcome everybody's views on this. So the first question I have for our panelists today is, why do you see gender challenges emerging during COVID? And what surprised you about these gender challenges? And I'm going to start by passing over to Sabina Rashid from Bangladesh.
I've got to unmute myself, I realize. That's the thing you learn on Zoom. Hi, everyone. Good morning. It's evening in Bangladesh. But I wasn't surprised. The reason why I say this is what the pandemic has done. It has magnified the already existing fault lines that exist in public health and development, the existing structural and social inequalities that exist. And if we look at emerging research, particularly on adolescent girls who are street vendors, street hawkers, the initial research just brings that together so well, because many are married early. We have very high early marriage. The pandemic means many of them are juggling children. They often have 2 to 3 children. They're 16, 17 years old. They have husbands who are also unemployed without jobs, or some are sick, or some are not working. So you have young girls who are talking about the pressures of taking care of households, taking care of children, and many of them couldn't sell their newspapers or towels or toys on the streets of Dhaka city. So what did they do? I'll just very quickly tell you. Mina is a young girl who walked to 30 houses one day when the shutdown had slightly eased, desperate for a job because they'd cut back on their meals. They were down to 1 meal a day. She was turned away because this was at the peak of the, waited a day when she saw some cars passing by and waited near the traffic lights so she could beg. But transmission fears meant that no one was willing to help out, as they usually do when they see these young girls on the streets. Mind you, they're not young girls. They're sort of mothers who are young girls. So just to kind of emphasize that the lives are really, really hard. They're worrying about food, economic insecurity. On top of that, I have to say a couple of main points, and then I'll wrap up, is young men who are also running households talked about this fear of not being able to provide for their wives, for their children, for their parents in some cases. So very poor households were affected. But for young women, there was one young girl who was pregnant, who was on the streets trying to hawk whatever she had because she didn't have a choice. I mean, this is the level of desperation. At another level, for many of them, there was a disruption of social networks and relationships. Landlords started demanding rent monthly, irrespective of the pandemic. Mind you, the shutdown was 4 months in Bangladesh. Everything was shut. 1.2 million people had no jobs. That's over 75% informal workers without any money, any income. So most of their relationships and negotiating, navigating with these landlords and landladies, young girls would talk about how their husbands would navigate, or they would if the husband was outside. And it was very stressful. Storekeepers, negotiating with storekeepers who were actually giving them credit for 3 months. But by April and May, they were getting desperate because there was an unknown uncertainty, this never-ending pandemic. And they said, how are we going to survive? Because food consumption had gone down. Finally, they talked about this disruption of networks with neighbors and family members. While some were supporting each other, others couldn't. You had families leave, go back to the village out of desperation. And you also found that in general, and I'll wrap up on this point, is that there was increased sort of fear. You had the economic, social insecurity, and you also had this fear of a pandemic, this all-pervasive pandemic, and they didn't have the living conditions to buy a mask, buy soap. They lived in congested living environments, but they were getting very biomedical messages. And young women were extremely vulnerable in this environment. And this is just sort of the initial data, that's what it's showing. Thank you.
Thank you so much, Sabina. Perfect timing. Next, I'm delighted to hand over to Denise.
Hi, everyone. It's a great pleasure to be here as well. So I'm Denise. I'm an anthropologist speaking from Brazil. It's noon here. And it's great to be here and talking with everyone about this. So from the Latin America perspective, in Brazil in specific, the surprises are similar to Sabina. There weren't surprises in terms of the root structural problems that we knew were very pungent in Brazil and in Latin America in general. It's such an unequal society, and there's so many problems that come from this. But what we are very amazed to see is how it's been playing out in our aspect political, how the political uses of the pandemic, and how it's been it's an outrage really in terms of some people are naming it as a genocide, of how certain communities, certain ethnic and in terms of ethnicity, how people are being treated in terms of political policies. So this has been a surprise. The amount of the ways in which the pandemic has been used politically and how these things have been interplaying, and how Latin American in general has been overlooked and not been playing out in different territories, in different categories. So these are some aspects that we can discuss later, and then we can discuss these ideas. Thank you.
Thank you so much, Denise. Can I just remind anyone who's attending, who's listening, who wants to ask questions, to use the Q&A function, please. I'm now delighted to pass over to Germaine, one point is Germaine is going to speak to us in French. So for those of you who are Francophone, you know, it's your lucky day. You're not listening to another webcast in English. But anyone who is unable to follow in French, there will be a simultaneous translation pasted into the chat box for you. So Germaine.
Merci Claire. Oui, la pandémie de COVID-19 a effectivement surpris à plusieurs anglais, notamment au niveau économique. Comme nous le savons déjà, en République démocratique du Congo, plus de 80% de femmes congolaises n'ont pas une source de revenus formels. La majorité de ces femmes-là travaillent dans l'informel, notamment les petits commerces, etc. Et avec la situation, elles se sont vues tout de suite perdre leurs activités économiques. Le peu de pourcentage de femmes qui travaillent formellement, elles aussi ont perdu une partie de leur poste, et d'autres filles, les filles scolarisées, qui se retrouvent aujourd'hui, certaines bien sûr, incapables de retourner à l'école à cause notamment des grossesses, de la pauvreté de famille, qui ne peuvent plus supporter les frais scolaires. Ça, oui, c'est une réalité, mais en RDC, mais elle a vraiment été plus prononcée à travers la crise de COVID-19. Et au niveau même de l'accès à l'information liée au virus lui-même et les mesures de prévention de la population, on a observé que les sensibilisations sur le COVID et les mesures de protection qui ont été lancées via plutôt les médias, l'Internet principalement, ou encore via des dépliants. Pourtant, toutes ces voies de communication sont peu sensibles ou trop peu utilisées d'ailleurs par les femmes ou les filles, particulièrement encore dans les milieux ruraux. Alors, ces femmes se sont vues vite exposées au virus par rapport aux hommes. Et quand bien même dans toutes les régions du pays, les femmes étaient majoritairement appelées à sortir de chez elles à la recherche de quoi nourrir la famille, avec moins d'accès aux équipements de protection individuelle ou à des équipements de taille appropriée. On va même constater qu'au niveau de mesures qui ont été prises en République démocratique du Congo, les confinements s'est finalement avéré malheureusement être un facteur de vulnérabilité pour de nombreuses femmes en RDC qui ont vu ainsi leur destin basculer dans l'horreur de violences qui s'est installée dans les familles et aux alentours à cause de la fermeture notamment des écoles, la restriction des mouvements ou les confinements obligatoires des populations. Et donc, les femmes se sont vues prises au piège contre les COVID et les violences sexuelles et celles basées sur le genre. Et pour finir, au niveau de la santé, on a observé que là encore, les femmes déjà qui ont du mal à accéder aux soins de santé, celles-là, elles se sont retrouvées au premier plan, comme d'ailleurs dans beaucoup de pays du monde, dans la riposte, dans la prise en charge des malades. Mais en même temps, on va encore observer un phénomène particulier, c'était la présence, les contacts plus marqués avec les malades de coronavirus dans le pays, tout simplement parce que à cause de la répartition, je vais dire, des rôles entre les hommes et les femmes en RDC, où les malades sont toujours accompagnés et surveillés par leurs femmes, leurs mères, comme l'avait la tradition. Et donc, les femmes, elles sont exposées soit en tant que surveillantes de malades, soit en tant que personnel de santé, etc. Et ce qui est encore pire est que on a constaté un grand déficit au niveau de la capacité des infrastructures de prise en charge de victimes de violences, plutôt des personnes atteintes du COVID, où par exemple on peut avoir un hôpital avec seulement 50 lits de réanimation pour plus de 900 000 habitants. Et donc, on va constater que finalement, la femme, elle est vraiment au centre dans cette lutte-là. Mais malheureusement, il y aura encore un problème au niveau de la politique de manière globale où on a observé un détournement de l'attention et des ressources essentielles des dispositifs des services de santé sexuelle et reproductive, y compris les soins de santé maternelle et les services liés à la violence sexiste, à certaines qui a certes entraîné une exacerbation de la mortalité, de la morbidité maternelle, une augmentation même des taux de grossesse chez les jeunes adolescents. Et donc, oui, il y a l'autre défi quand même frappant, c'est qu'il y a peu de statistiques autour de toutes ces réalités qui ont été vécues et que les données qui existent, effectivement, sont des données collectées de manière dispersée. Mais voilà un peu la réalité et toutes les surprises que nous avons constatées pendant cette période de coronavirus en République démocratique du Congo. Merci.
Thanks, Germaine. And last but very not least, Anne.
Thank you very much. My name is Ngunijiri from LVCT Health. And just a bit of what we do at LVCT Health is we primarily program for adolescent girls and young women for HIV prevention, care and treatment services and testing, as well as gender-based violence services. So one of the things since the announcement of COVID pandemic in Kenya back in March was, of course, the government response plans would be put in place to try and curb the spread of COVID. But one of the surprises, I think, for everyone, including the implementing partners and the government stakeholders as well, was the limited attention that was given to what is turning out to be the shadow pandemic. So everything was laid in place in terms of how and what to do to prevent the COVID pandemic from spreading, but not enough attention was put into the ripple effects of what these response plans would be. For example, we had curfews, we had cities literally shut down. Of course, what this led to was the social disruptive things that happened, like families being separated because of curfew and lockdown. And essentially that left the women, the girls, the children, the most vulnerable in our society. It increased their likelihood of experiencing gender-based violence and violence against children. Another challenge that came about again with COVID was the loss of livelihoods for a lot of the people, particularly in the informal sector, where you have especially young women who are in the urban informal settlements, doing the informal work like domestic care, family care. All of a sudden now that was taken away from them as a source of livelihood. And what turned out because of that was them engaging in exploitation and being at a risk of exploitation and abuse as they seek their livelihoods. So as has been said by everybody else, the adolescent girls and young women are the ones who suffered the most because of the increased rate of gender-based violence. We've certainly seen that at LVCT Health in our programming. Those are the numbers that are there globally, but just the actions that were taken or not taken at the time that this shadow pandemic was coming up was a surprising fact. Again, with the school closures, which was one of the response plans to COVID. And there's a reason why the response plans are there. Let me just say that it's not an option for us not to obey the government directives. But however, as a result of that, there's been an reported increase in teenage pregnancies, the Romeo to Juliet cases, even cases where the perpetrators are beyond 18 years with the adolescent school-going children. So again, that was one of the things that came up during COVID related to gender. And I believe not enough was done at the time that it was emerging to be able to ignore the shadow pandemic that we are now having to deal with.
Thank you so much to all our participants. So the next question I wanted to ask you is, are there particular women that have been more affected or more vulnerable to the effects of coronavirus in your respective countries? And why are these groups particularly vulnerable? So I'm going to go in the opposite order. So back to Anne.
Okay, thank you, Claire. Kenya, as any other African setting, there's always been issues with patriarchal society where there's a lot of gender inequality. But then during this period of COVID, that seemed to have intensified. And certainly from our program data, the ones we're seeing at our greatest risk are those ones between the ages of 10 up until 24, just from our program data, because those are who we program for. But generally in Kenya, it seems to affect all young women up until the age of 49. And this is, as I said, primarily because like the ones who are not going to school would have otherwise been in school, which is a known protective factor. They're now being engaged in unpaid family work and care work, particularly in the urban informal settings. You also have women who'd otherwise, again, been engaged in income-generating activities. They're at home now, they cannot be able to do that. So that places them at an additional risk of intimate partner violence, particularly in domestic violence, where we can almost make the conclusion that if it were not for COVID, they would not otherwise be at home and not earning a living. So certainly COVID has increased the risk for that particularly group, the young women and the adolescent girls who are at home. Another group that has also come up, because we do program for key population, is the risk towards female sex workers. Now, if you look at traditionally how they work would be in hotspots within the towns where we work in. But now because of the curfew, everything suddenly goes, it gets shut down by 9 p.m. Then they have the additional risk of having to go and meet their clients in their houses. And we've had the unfortunate cases where even for that target group, particularly the female sex workers, where they reported increased cases of violence against them or even death. Because again, by the time the FSW is going to a client's home, they're not in control of the situation as it would be if they were at their hotspots during normal times outside of COVID. So because of our gender inequalities that seem to be more pronounced during this period, and because of the curfews and the response plans that are there, those are the key groups that data is showing from our program and from our nation as well as to be the ones who are being disproportionately affected by COVID. The adolescent girls, the young women, and the key population, specifically the female sex workers. Thank you.
Sam, and the same question to Germaine.
Yeah, thank you. En RDC, en République démocratique du Congo, oui, il y a, je vais dire, 3 grandes catégories de femmes qui ont été plus affectées par la pandémie de coronavirus. Il y a notamment toute cette catégorie, la masse qui est d'ailleurs majoritaire de femmes qui œuvrent dans les secteurs informels, comme je l'ai expliqué tout à l'heure, qui se sont en fait... Comme vous le savez, en République démocratique du Congo et en Afrique de manière générale, les femmes qui sont dans ce secteur représentent autour de 92% des travailleurs dans les secteurs informels. Donc, ces femmes-là, elles se sont tout de suite touchées par la pandémie parce qu'elles ne pouvaient plus exercer normalement leurs activités. Et encore, dans les pays où il n'existe aucune sécurité de l'emploi, ni aucun filet de sécurité, si une crise comme celle de Covid les a privés de leurs revenus. La deuxième catégorie qui a été plus touchée, ce sont les filles en âge scolaire. Ma collègue tout à l'heure l'a expliqué, c'est une réalité aussi en République démocratique du Congo où aucune mesure, les filles qui se sont retrouvées à la maison étaient exposées plus aux violences sexuelles au sein de leur famille, même aux alentours. Et encore plusieurs cas de violence, de grossesses indésirables ont été rapportés dans les pays pendant cette période-là. Et comme dans les systèmes éducatifs formels, les filles qui se sont retrouvées enceintes ont du mal à retourner à l'école, les taux de retour effectivement à l'école semble être à la baisse pour les filles. L'autre catégorie, ce sont les femmes rurales. Ces femmes rurales-là qui, d'une part, dépendent des services qui sont offerts par les villes, elles dépendent des services qui sont offerts par les villes, notamment des services sanitaires qui ne sont plus présents dans les zones rurales. Et lorsqu'ils y sont, nécessitent des ressources provenant souvent des centres urbains, encore une fois, comme point d'entrée. Et lorsqu'il y a eu cette fermeture ou le manque de contact entre les villes et les milieux ruraux, les femmes se sont vues privées d'accès à ces soins de santé, d'autant plus qu'elles ne peuvent même pas se déplacer vers les milieux urbains. Alors, on va constater que ces mesures ont vraiment isolé ces femmes, en plus qu'elles ont déjà des difficultés d'accéder aux soins de santé et à d'autres ressources. La situation les a encore isolées davantage et on observe qu'il y a de plus en plus de cas de personnes vulnérables dans les milieux ruraux en République démocratique du Congo. Voilà, c'est vraiment à ces trois niveaux que nous avons observé plus d'impact dans le pays. Merci.
Merci, Germaine. Okay, Denise.
Yes, I think this is a very important aspect for us to discuss, and how what we mean when we say women. We always try to open up that category and think of ways of women in which territories, in which geographies, in which contexts, to help understand the impact, because the impact is very different. And we've been seeing this here in Brazil. And now 6 months, almost 7 now, in terms of the timing and the temporality of the pandemic. It's been very clear how here in Brazil, Black women, young Black women and indigenous community have been, like I said before, very much impacted in the disastrous effects that this has. And in terms of the global and South and North policies, this has been very clear as well, when we see how these policies have been playing out and the differences of political attention about these cases. And in here specifically in Brazil, during this time, we've had 3 ministers of health. We are going through a very, very serious political crisis. So when you put these 2 things together, the pandemic and the political crisis and the access to data, we've had data blackouts, and we're still trying to really understand what's been going on. Testing, some states have been totally ignored. And we don't really, it's almost like we're walking in the dark, but we know, but thanks to our experience and our strong health system, universal health system in Brazil, it's been very clear how social movements and different civil society has been really important in putting this out and publicizing this and making this more visible. In terms, so when we say women, it's very, for us here, it's been very important to really understand which women, who are we talking about, what languages are they talking, how are we going to access them, and just really basic, who is in the other end that we're trying to have a dialogue with and access, and what are their needs and demands. So I think it's really even internally inside countries and internationally. So I think this is a really important topic that we need to keep in mind when we talk about gender.
Thanks, Denise. Sabina.
So I was just thinking about this question because there's so many different levels of poverty and insecurity and intersectional factors. So, I mean, if you look at young adolescents who are disabled, or if you're looking at transgender population, so what I would say within this group that we're doing research on is one of the groups that we're looking at, the fact that they're adolescents and they're leading adult lives, having children at 15 or 14, juggling household chores, taking care of family members, walking in the streets, working to just have an income is something that no 14 or 15-year-old 16-year-old should be doing. So they're vulnerable by that. Secondly, if you're under 18, you don't get ID cards, which means that the economic packages that the government has rolled out, they're not eligible for it. because you have to be 18 and above to get that ID card to register. Having said that, the distribution's been uneven, mismanagement is rife politically with who actually got food. So I was going to say, and then there's street hawkers. So you can't even get more informal than being a street hawker. You run to the streets, you sell a couple of toys, a towel, you earn some money, you run back, and it's erratic income. Particularly during a lockdown, there's no income. And that's for many families. So they're under 18, they're living adult lives. Income is erratic for many of the poor, but particularly when you're young and trying to run a family or a household, that's a lot of burdens. Secondly, for some of the ones that we've been following, they actually had jobs. They got out of working as street hawkers. And now they've gone back to hawking in the streets because of the pandemic, because jobs are just not there. Finally, they're also competing with adults for jobs, like pulling a three-wheeler or labor work. But these young men are 16, 17, 18. These young girls are standing for hours as maids looking for jobs in domestic. So in many ways, they have very, very strong levels of vulnerability and they're at risk of not only emotional, but mental and physical. And a recent study found that adolescents have high levels of malnutrition as well, not to get into the pregnancies and the risks and all of that. So I would say here's a group. And some of this makes me think of, if you look at the political, the social, the economic, and the structural factors, as Denise was saying, and we bring it together, you're talking about a sort of social injustice, like the right to health, the right to basic services, the right to live lives like other citizens that I have sitting in my house and on Zoom, that many don't, means that only a socially just model can address gender inequalities and equities, but also address some of the underlying causes, because many of these young girls who are double or triple burdened are living lives not separate from their husbands or their brothers or their fathers, who are now without jobs, and they're very stressed, and there's a lack of food. The difference is a lot of these young girls are not so mobile. They're much more insecure about crime and are worried about if the police do something to them, particularly when there was a shutdown and there was only police on the streets. Men were worried about being beaten. Young girls are more worried about rape or sexual assault. But I just wanted to say, I think we really need to think of some of the underlying conditions that really inform. And I saw a question there about education. When we're looking at adolescent girls, the boys were still roaming around. The slums slightly out, but the girls were much more immobile. And that had a lot of effect on sort of feeling sad and depressed, being confined, because they couldn't go to schools. Everything was shut for those who were going to school. So I really think that we need to bring in the nexus of rights, health, and structural justice, structural ways of looking at this pandemic, because this is not going away and we're going to have different forms. And it's not the first time this has happened to the poor. It's just as magnified because it's called a global pandemic. But I've seen through famines and earthquakes and floods, many of these vulnerable groups, and particularly young girls, but even other young men and family members, go through extremely difficult deprivations and very precarious, a lot of sort of, I would say, precarious lives they lead. Thank you.
Great, thank you, Sabina. So my name is Rosemary Morgan, and I'm based at Johns Hopkins Bloomberg School of Public Health. And it's my pleasure to moderate the next section, which is the audience Q&A section. And I see we've had some really great questions come in already. So if you have any questions for our participants, panelists, please do input them in the question and answer box so we can make sure that they get asked. I thought that was an excellent discussion to think about, and in our overall project, we're really thinking about what are some of the surprising things, gendered impacts of this pandemic. And I think all the panelists, especially in the responses to the second question, even brought out that a little bit more. Some of the specific vulnerabilities and intersecting social identities that make certain groups more vulnerable that we really have to pay attention to. So I think I'm going to go to Rachou Kuenzi, who at the very beginning, Sabina, asked a question during your first response about what was most surprising to the pandemic. Her question was, with states facing dramatic budget constraints, how do we ensure that the cuts do not further harm women, for example, through cutting family planning services?
I wish I had some easy answers, then I wouldn't be. But I think, you know, it's complex because first you need state commitment. So if you look at it, the Bangladesh government has a Ministry for Women and Health, Welfare, and they have certain stipends, social safety nets given to women left behind, disability groups, elderly. If you look at family planning, reproductive health services, one of my colleagues did a recent study. Vaccination is being affected, reproductive health services have been affected, health systems are weak anyways. Then you have a pandemic, then you have weak governance, then you have a moderately very weak health budget and allocation. So it's a complicated space. I'm part of Bangladesh Health Watch, which is a Citizens Watch group. And some ways, and I don't think it's simple that it's just linear, you go and say it. I think it requires sustained efforts by across sectors. So not only just academics, NGOs, other stakeholders, human rights lawyers, to get to the table and start coming together to have discussions about vulnerable groups and how women in some ways are greatly affected amongst other groups. And I think in that way you can raise issues. In Bangladesh, a lot of awareness is raised through publishing articles in newspapers, because every minister is reading the newspaper. That's one way, and I think you need to work across sectors to put pressure, because with budget cuts, family planning, reproductive health services, basic services, are, particularly during the peak of March till about May, it was very bad. I mean, beds were overflowing, people were being turned away. And then there was an inherent sort of fear of COVID and going to these clinics or facilities if you were sick, if you were pregnant, because you didn't know of the transmission. So it's a very complicated space. And I do think that, there's a lot to be learned, particularly. And I think nothing can happen overnight, but we need some commitment about health. What does it tell us about lessons for health systems? And what does it tell us about working across health sectors, but also working across disciplines and sectors in country to address some of this? And development partners have a huge role to play, particularly because they fund many agendas. And it's important that they're part of that discussion where it isn't a siloed approach, but a more comprehensive approach to looking at it. Thank you.
Thanks, Sabina. So Rohini Pandey has asked two quite pertinent questions that are similar, but I'm gonna start with the first one because it's specifically directed at you, Germaine. And her question is, could you talk a little bit about government and health service response to women's particular vulnerability that COVID has highlighted? What is being done and what seems to have promise? And before we move to Germaine, just for the other panelists, Rohini expanded on that question to talk to all panelists to ask you to talk about any programmatic efforts that you know of that are ongoing to address gender inequality in this pandemic, and whether there is research alongside to assess effectiveness of different approaches. So can the other panelists just sort of think about a potential response to that question while Germaine is answering the question about particular government response in the DRC. And for those of you who joined us, there will be translation in the chat box, so please do watch out for that if you are unable to speak French. Germaine, over to you.
Thank you. Oui, en République démocratique du Congo, la crise a été gérée, je vais dire, de manière assez particulière, notamment c'est probablement lié à la crise elle-même au niveau politique. Et aussi, cette crise-là qui n'a pas permis une bonne coordination ou alors d'attirer de l'attention particulière à certaines catégories de la population, notamment les femmes avec un certain niveau de vulnérabilité. Ce qui s'est observé en RDC, c'est qu'il y a eu des mesures globales, en tout cas qui touchent tout le monde sans spécificité liées au genre, ou alors aux besoins particuliers des femmes. Voilà, aujourd'hui, nous sommes incapables de vraiment préciser quelle a été une mesure plus pragmatique du gouvernement congolais pour la femme de manière particulière. Ça n'a pas existé et c'est ça, effectivement, les défis qu'il y a eu, que la pandémie a plus créé des déficits encore davantage entre les hommes et les femmes sur tous les plans, au niveau économique, au niveau de la santé, au niveau social, parce que tout simplement, il n'y a pas eu une mesure spécifique qui a accompagné cette crise en faveur de la femme. Voilà.
Thank you, Germaine. And I see we've lost Anne, but she'll probably join us back when she's able to. So maybe I will direct this question to you, Denise, the one I asked previously about any programmatic efforts that you know of that are ongoing that address gender inequality in this pandemic.
I think here in Brazil, we've been seeing how important research in all areas has been to inform policymakers and programs in general. It's been really interesting to see, speaking from the social science side, it's been really interesting to see these differences in qualitative data, not only epidemiological, more quantitative data. So interdisciplinarity has been really key in it. Like for now, the discussion now with vaccines, for example, it's been very interesting because now in Brazil, we have a really strong anti-vaccine movement and how these other aspects of trust in science and scientific information and evidence. So also now social science has been called on to help with that and even understand the context. So that mixed with gender and how women have been in terms of the programs some has happened, but it's been, like I said, it's been very hard from our side here in Brazil because the ministry that is responsible for policies for women in general and it's been very anti-science, and so it's been very hard putting these programs out. But there are a few, but not very much based on scientific information.
Thank you, Denise.
Very hard.
Yeah. Yes, especially when there's that contention between science and
very strong, yeah.
So there's a question from Sophia Ahmed that's quite similar to Rohini's question. So Anne, I think I will direct this one to you because it's basically the same question asked in a different way, which is, are there any examples where gender considerations in the pandemic response were taken into account, and what were the outcomes?
I'll give in relation mostly to the program that we do at LVCT Health with adolescent girls and young women, now that we recognize that they are at one of the most vulnerable populations during this period and with the school closure. So what we've done deliberately is income generating activities for them, because we understand the relation between poverty, gender, and COVID as well. So especially for the young women, now that every other household needs to have a mask, or every other citizen needs to, that's something that we've encouraged them to carry on doing so that it doesn't affect the livelihoods that they would have otherwise sought from somewhere else and has been stopped by COVID. We've also deliberately not lost touch, should I say, with our mentors. Normally our mentors during this period, again with COVID, it kind of started with them going on a go slow. So we've deliberately adapted the use of technology and getting them to pass on messages to the ground, to the girls on the ground. So we do a lot of IC information education and communication materials, or not just on GBV and the risk factors and what to do should the girls experience gender-based violence, but also COVID messaging. So it's been two-way, and most of the mentors have been receptive to it, and they've also been able to cascade the information down to the girls. So those are the unique things that we're doing in our program right now during COVID. We've also enhanced our telecounseling. There's a lot of hotline numbers coming up now, because again, we understand that movement to the facility may be restricted, but we are hoping some of the adolescent girls and young women and the key population that we're working with have access to a mobile phone if it doesn't place them in additional risk. So we've enhanced our telecounseling services, a nationwide number where all the survivors, or those ones who are at risk of, regardless of age, it's a toll-free number, can ring in. They get what we term as lives, the psychosocial first aid, where it goes as far as even assessing their immediate risk over the telephone, and if need be, our telecounselors have been trained to be able to link the survivor to security services in case there's any need for evacuation at that point, wherever it is that they are. So we have deliberately expanded our referral pathways and networks and made them as effective as can be in terms of the numbers that we're giving out there. And we've also done put in a lot of effort in engagement of the community health volunteers. Even with the pandemic, they still have their role to play in terms of awareness creation. So we are loading them with messages related to gender-based violence. And also they have been trained, or we have trained them on how to offer psychosocial first aid. So they look, listen, and link. Because they're out there in the community, we understand that the community members, the adolescent girls, perhaps some of the assumptions that we had to make were they're fearful to come to the facility because of COVID itself, or otherwise their movement has been restricted. But with CHVs and how the community health volunteers and how they work in Kenya, they almost have unrestricted access to households. They're accepted at household level. So beyond monitoring their mother and child indicators, we've purposely trained them on how to offer that psychosocial first aid, where they can be able to look at the situation when they visit a household where there might be an adolescent girl with or without the offending caregiver present. They listen to the stories that they are told, and also finally link to the facilities where to the health facilities where now those ones who are survivors can actually access comprehensive care. So those are some of the deliberate programmatic actions that we've taken during this period to address intimate partner violence and violence against children, and that's happening in the community now. Thank you.
Great, thanks, Anne. And we've just been informed by Rupa Dutt that we can go over 10 minutes, so that gives us a little bit more wiggle room, which is nice. Sabina, I wanted to direct that question to you now as well from the Bangladesh context. What is being done from a gender perspective to address these issues?
I was going to add to that, but make a slightly different point, because we're talking about gender inequalities, because there are many NGOs, there are actors, there's government doing various programs and reach out. Some are effective, some are not so effective, but there are activities on the ground. Bangladesh has BRAC, one of the largest NGOs in the world. It has a reach out to the entire country. They have a gender focus unit reaching out to document violence, give referral services, having community health workers go out to promote masks, to promote health messaging, to refer them to hospitals for uptake. But I just had two different points, just listening to us speak, if you don't mind me sharing. One is, in many of these countries, as I hear others, a lot of the informal workers are women. And, with the pandemic, it just struck me the interconnectedness of countries, global, local, whatever you call it. So in the Bangladesh case, when the pandemic hit, many countries canceled their orders. And what happened was these orders were ready to be shipped. They were paid for. They weren't paid for, sorry. The workers had done the work. They were canceled. About 1.3 billion loss of the garment industry, which means how many women at the bottom of this hierarchy didn't have money or jobs because these garments were were sort of affected. So I want to raise the point that when we look at national level, we can't forget the interconnectedness of trade aid, of accountability, of, some kind of, when I talk about social justice, I'm talking about accountability from countries across within, particularly if you're doing trade. If you look at vaccines now, a large percentage is the resources, the know-how, the opportunities to access it is in developed, richer countries. So, the pandemic raises issues about vulnerability, poverty, and about also, if I talk about young garment workers, where there's sort of unequal systems operating at many different levels. I just wanted to say that because I thought it's very important. We reduce it to some micro-national level, but the politics, the global politics, and those agendas also have to be addressed, because we are in a foreign policy conference. And if you're talking about foreign policy, trade aid policies, we also have to critically reflect on these questions, because directly affects the most poorest, the most marginalized, and the different groups, whether you talk about family planning budgets, or if you talk about abortion rights, XYZ. So I just wanted to flag that. Thank you.
Thanks, Sabina. So I've left this rather important question to last, and I'd love to be able to give each panelist a chance to respond to it. So the question is from an anonymous attendee and who's thanked you for such an informative session. And their question is, what are the largest and most consequential research gaps that currently prevent policymakers from addressing the gendered impacts of COVID-19? And then also, how can desperate stakeholders, including those from government, academia, and the private sector, work together to fill these gaps? Would anyone like to start us off on that question? Yes, Sabina, please go ahead.
If no one's talking, I'll just say my last bit, which is, you know, I'm in Bangladesh where public health is very clinician-led. Public health in general is very biomedical. So it's very important we have this panel where we look at gendered effects. We look at poverty, we look at vulnerability of women. If you look at COVID times, it was about food insecurity, economic insecurity, violence, crime. And if we look at research, and Denise referred to this earlier, you've got a lot of interesting surveys that are very important. You got epidemiologists, statisticians. Where is the social science? Where is the longitudinal in-depth research that you need? Because these are vulnerable communities, families, populations. And if you had rich in-depth data, you could actually understand the complexities of how they're managing the economic, the social, the health. And that's extremely important for feeding in evidence to policymakers, to practitioners, to other actors. But what you have is if you have numbers and that gives you sort of the breadth of the prevalence, but you don't understand the contextual differences, particularly if you're trying to identify who's more vulnerable, which women of which age group are more vulnerable, which category are more vulnerable. You need those kinds of studies. Otherwise, these questions around what kind of programs, how do you design it effectively, what kind of very focused gendered policies do you have, is impossible and difficult to do without in-depth longitudinal data. So I think here we need to have a shift in the funding bodies, in the research people do, in terms of not qualitative as some anecdotal quotes, but how social science can work. And Denise referred to this, so thank you, Denise, with other interdisciplinary groups, because we can work very well together, complement each other, and really inform evidence and really inform policy. And I really believe that being a medical anthropologist who's always sitting on the periphery, and now we're being asked questions about the pandemic, but I think it's very important from a public health development perspective if we want to change women's lives and improve rights. Yeah. I'll finally shut up. Thank you.
No, thanks, Sabina. Denise, would you like to respond?
Yeah, I think I answered the wrong question before because I was looking at this one, but that exactly, Sabina. This is really interesting, and in my context, funding, international funding has been key when local governments aren't prone to fund these type of programs. International funding and sensibility for these aspects have been really important here in Brazil now. And I think our project speaks to that. Their availability in funding qualitative work, so now, as we're doing here, as we're starting with this project, will be fundamental in informing policies later on. And even the timing of this, because the pandemic has different timings for different contexts. For example, when Europe is talking of a recovery phase, we're very far from recovery. So all of these aspects are contextual, and only social science that can help shed a light on this. So I think interdisciplinarity will be key from now on to inform us better about the realities of and how people are really living these vulnerabilities.
Thank you, Denise. And Germaine, would you like to respond?
Oui, les gaps qu'il faut changer ou qu'il faut vraiment, sur lesquels on doit travailler, à mon sens, dans les contextes de la République démocratique du Congo, c'est en fait la déconnexion que nous avons observée entre les politiques, les personnels de santé et les scientifiques. C'était trois domaines qui ont évolué séparément, et cela a fait effectivement qu'il y a eu beaucoup de difficultés dans la gestion de la crise. Et donc, ce qu'il faut améliorer en République démocratique du Congo au premier plan, c'est de développer une politique scientifique de manière à obtenir des évidences et particulièrement sexo-spécifiques, donc qui tiennent compte du genre et qui permettraient alors d'éclairer les décideurs politiques dans la phase de gestion de la crise ou même la phase post-Covid. Et donc, concrètement, la RDC devrait travailler sur ce point-là, mais aussi elle devrait veiller à ce que ces réponses à elle incluent en fait cette approche de planification des redressements, je vais dire, post-crise, et aussi qui garantit l'égalité dans l'économie des soins, mais aussi dans les autres domaines de la santé. L'autre élément est que moi, personnellement, je crois fermement que l'État congolais devrait, et les autres parties prenantes, bien évidemment, devraient intégrer dans sa politique de riposte les problématiques de violences basées sur le genre et les violences sexuelles pour être certains. Ils doivent se rassurer que les victimes continuent de recevoir l'aide nécessaire pour que les acteurs qui leur offrent de l'assistance puissent continuer la lutte contre ces violences dans un environnement plus ou moins rassurant. Et donc, c'est à ces trois niveaux que, en fait, les trois gaps importants qu'il faut relever. D'abord, au niveau scientifique et l'interconnexion entre la science, les politiques et les services ou les personnels de santé. Et deuxièmement, au niveau de l'implication des hommes et des femmes désormais dans la planification du redressement post-crise. Et comme je l'ai dit aussi, c'est rassurer qu'on ne perd pas de vie, qu'il y a des conséquences, qu'il y a des violences et pour lesquelles on doit continuer à lutter malgré que la crise est là aussi. Voilà, merci.
Thank you, Germaine. And Anne, we just have about a minute or so left, so just a brief response from you about what is the most significant, largest consequential research gap?
Let me just even say from the perspective of Kenya, the president just declared GBV as an issue during this COVID very recently. So as a nation, we are not doing very well in highlighting the difference between male and female being affected by COVID, certainly by GBV. So then that makes it difficult even for the government to be able to push for the essential services for post-violence care, just because, again, even in the current situation, a lot of the shift seems to be moving away from COVID into the politics, with the elections coming up in about a year or two. So there's certainly a gap from a national level on collecting data specific for women. So that way we do not know how to address the different vulnerabilities. And in the meantime, our adolescent girls, young women, the key population are still suffering at homes in the community. The policies that have been put in place, the paper is there to prove that it's there, but on the ground, things are completely different. So even before we go into research, just the programmatic level, the national actions plan, they're not being effected as fast as they should be. So certainly on research, we have nothing to work with. We have no data to work with essentially, because nothing has been produced as a nation. So there is a huge gap. Even for the ones where the implementing partners have done a bit of quantitative, it's fair enough ticking boxes, but the real story behind of what is happening on the ground hasn't been collected yet. So yes, there is a very big research gap. Nobody understands beyond the numbers of who's been affected by COVID. Certainly GBV data is missing, and that is having an effect on the people on the ground in terms of giving them the care and support that they need or planning for it. Thank you.
Thanks, Anne. And we're at time now, so we just wanted to thank everyone for joining us today and for your very, very important and interesting questions. I really did enjoy that discussion. And a final question of that last one was about how can disparate stakeholders work together to fill these research gaps. And through that, I'd like to invite anyone that's on the panel or on the at this webinar today to join our Gender and COVID-19 working group. All of us here, we're part of a Gender and COVID-19 project, but also part of a larger working group that has up to 500 members across government, academia, and the private sector, as well as civil society, working to identify these research gaps, to collaborate on key issues. And if you're interested, please visit the website of our project, and I put it in the chat box there, genderandcovid19.org, and just send us a message, and it'll that you're interested in joining the working group, and we will send you an invitation for that. And that's one way that we're really coming together. That's been a real highlight, I guess, of a lightness in this pandemic, is the ability for us to connect in ways we never did before, you know, to really bring us together across geographical areas, across sectors, in a topic that is important and relevant for all of us, regardless of what our areas of expertise are. So we welcome you to join those discussions with us, and thank you very much for joining us today. Bye.
Thank you.
Thank you all. It was a pleasure.
Thank you. Bye-bye. Thanks,
Bye-bye.
Rosemary.
Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Please do click on it. The next session links are in the chat box for the networking session. So please do click on those if you're interested in joining a networking event.